This is Dr. Theal. What I'd like to demonstrate for you now is an example of completing a note for an upper endoscopy, also known to those in the business as an EGD or esophagogastroduodenoscopy. We have a pre-completed note already set up which has a lot of the fields filled in that I typically use. I'm going to go through this scenario by explaining all of the steps in detail first, and then I'm going to do the same note without any explanation to show you how quickly it can be completed. So I'm going to open up now my pre-completed note for an esophagogastroduodenoscopy, and this patient already has some information populated in terms of previous procedures that they've had and some medications that they're taking. I'm going to go ahead and include some of that information in my note because it saves me time having to do it later myself. And the first section of the note essentially has some components that are required for me to fill in. The date of the procedure, the system typically fills in the current date, which is only 2 clicks to do that. The indication for the procedure. So in this case, this is a patient who had some bleeding. So I'm going to put the indication as an upper GI bleed, and they had some melena, so that was the reason why they were diagnosed with an upper GI bleed and needed a gastroscopy. All of the other sections of this first portion of the note are filled in, including how I typically explain my consent to the patients with their risks outlined, so that that's covered off every time, that the patient's blood pressure and oxygen saturation is constantly being monitored, and so forth. In the consultation information, I've already had the system fill in for me the home medications, or the current medications, pardon me, as well as previous procedures the patient had. And I'm also going to include some diagnoses and problems that the patient already has on file in the system. In this case, this is a patient who has a history of hypertension and cirrhosis of the liver. And those are standardized diagnoses that are categorized using SNOMED CT terminology. And then lastly, I want to add some narrative text about this patient that helps to tell the patient's story. And I'm going to do that using speech recognition. You'll see the words come out as I speak them into the microphone on the computer. This 54-year-old gentleman who has a history of hypertension as well as cirrhosis presented to the emergency department with a 1-day history of melena, as well as pre-syncope, and shortness of breath, period. There was some nausea but no vomiting, period. There was no syncope, period. In the emergency department, he was transiently hypotensive and required intravenous fluids, period. And emergent gastroscopy was required to determine the source and treat upper GI bleeding, period. Okay, so the text rendition was actually very good, and I don't think there are any errors that I can see, so I'm going to move on. I can also complete my physical examination here, and I have a macro which automatically allows me to fill in a complete negative exam if everything was normal. In this case, I'm going to say that there were a couple of pertinent abnormalities. Instead of there being no organomegaly in this case, distended abdomen, shifting dullness suggestive of ascites. There we go. So I've completed my physical exam, and now I'm going to move on to the actual procedure. This patient's having a gastroscopy, and I've already indicated by filling in those blanks as that's the typical way I perform my procedures. This patient received sedation using anesthesia, and we didn't need to use any topical anesthetic. The patient was in the left lateral decubitus position. The visualization was excellent. I filled in most of these terms again because this is typically what I find when I do my procedures. I was able to complete the entire examination to the second portion of the duodenum, which is pretty standard for a gastroscopy, and there were no difficulties. The procedure was tolerated well. Now I can move on to the findings. In this case, I've automatically filled in normal findings for each of the sections of the note because this saves me time if the procedure is normal. But in this case, I did find a couple of abnormalities, and so I'm going to document those here. The first thing I noted was that the patient has esophageal varices, and these were small, but there were several of them, and they were at the gastroesophageal junction. There was no sign of any active bleeding or recent bleeding. So by clicking the terms twice, it actually puts a red cross through it indicating that that was a pertinent negative. I didn't see any stigmata of previous bleeding either. Because they were very small, I didn't need to perform any band ligation, so I'll leave that part blank. The squamocolumnar junction was normal, and it was 40 centimeters from the incisors. In the stomach, I actually found an ulcer, so I'm going to document that here. The ulcer was located at the antrum of the stomach, and it was medium in size. It was about 7 millimeters in diameter. It had regular edges. Now, what we filled in with our template is we've created several places where the physician can use standardized scoring scales that are based on research in the literature to document their findings. And the idea behind this is that by using these standardized scales, it not only improves quality, but also helps to make comparable findings more straightforward between patients or between examinations at different points in time on the same patient, and also helps with research because then we're documenting our findings in a standardized fashion. So in this case, for a gastric ulcer, we have the Forest classification, which is a research-based way to classify different types of stomach ulcers. And in this case, I found a clean-based ulcer, which is a Forest Class 3. Rather than the physician having to remember what they found or how it corresponds to the standardized scale, we've prompted the physician with all the possible choices here, including the descriptions for each of the classes, so that it's a very good memory aid. This was suggestive of a benign ulcer. I didn't think it looked malignant. And in this case, no intervention was required because it was not bleeding. And those were all my findings. The next thing I'm going to do is insert some images that I took during the endoscopy, pictures of the findings on this patient. Okay. So I've inserted my pictures, and I'm also going to insert a picture of the stomach, and I'm going to indicate where I found the ulcer. And include that in the note. And finally, I'm going to dictate my impression now that all my images are in place. This 54-year-old gentleman who presented to the emergency department with melena in the context of cirrhosis and hypertension was found on gastroscopy to have a clean-based antral ulcer, period. He also had small esophageal varices, which had no stigmata of recent bleeding. And did not require banding, period. The ulcer itself was not actively bleeding and did not require any endoscopic treatment at this time, period. I would recommend proton pump inhibitor therapy for this patient, period. And finally, I'm going to add my diagnoses. And similar to the colonoscopy note, this section of the note allows me to use structured SNOMED CT-based diagnoses, which will then be populated onto the patient's chart. In this case, I found esophageal varices, and I also found a gastric ulcer. So I'm going to put an acute gastric ulcer and esophageal varices without bleeding. So those are my two diagnoses. And this is actually an inpatient, so further follow-up will be undertaken by the managing physician. So I'm going to leave my note at that. This is an example of how the note will appear to the attending physician when they see the patient on their inpatient rounds, with all of my narrative text as well as my physical exam, my procedural findings, the pictures and diagram of where the findings are, and then my recommendations.